Hello, I'm Dr. Jennifer Jansen, Chief Clinical Officer here at the Zepf Center. In honor of Recovery Month, we're going to have a conversation today with one of our prescribing teams about what recovery looks like to them and how they contribute to an individual's recovery process. We'll talk a little bit about what medication-assisted treatment is, how clients might access treatment services here at Zepf Center, pros and cons to readmission, the importance of building rapport, and also addressing stigma as people work towards recovery. I hope that you enjoy our conversation. Welcome, Dr. Durrani. I'm excited that you're here to talk with us for Recovery Month. And you have had a long career in medicine, much of which has been in addiction treatment. Can you tell us a little bit about your passion for addiction medicine and how you got started in this field?
Thank you very much, Jennifer, for giving me the opportunity to speak and educate regarding addiction medicine. Addiction medicine is a field that specializes for, and the provider can evaluate and diagnose and treat those patients who have substance use disorder. And I've been in family practice for almost 3 decades. And 25 years ago, a fellow physician asked me to cover inpatient hospital patients while that doctor was away. And without thinking, I said, yeah, no problem, I'll just cover. And realized that that doctor was doing inpatient alcohol detox and substance use, which I was not practicing at that time. And but I said yes, and the doctor was out of town, so of course I was getting all the calls. And after 3 nights of unrestful nights and no sleep, and I felt like I was literally living on the floor because me being perfectionist, wanted to make sure I see the patient, take care of the patient, and I was like, I don't know why I did that. I should have not. I was like, that's not what I do. But at the end of the fourth day, when I went for the round and I saw those patients and how good they were feeling, and they were able to have a conversation with me and say, thank you so much for taking care of me. And that was it. It was like, oh my gosh, they are just like another patient who have diabetes and high blood pressure or stroke, and they come to the hospital and we take care of them. And that was the start of my career. I just fell in love with it. I believe in it because addiction is a chronic disease. And I never look back.
Well, I'm glad you had that opportunity and you got hooked in that moment. You certainly bring a passion for that here at Zepf Center and the care that you provide to our patients. Let's talk a little bit about medication-assisted treatment. What is that? How do you explain it?
So medication assisted treatment, there are medications that they are approved by FDA, like methadone was approved in 1970. Okay, and then the Suboxone came around in 2000. So Suboxone, methadone, and Vivitrol injection. These are the 3 medications currently approved to treat patients with substance use disorder. And then there are differences in how these medication works and how you start the patient on it. And it's evidence-based. It shows that it helps with the patient addiction and how their brain chemistry change once they start taking these medication, and how the fog is lifted off when they are not using illicit and just using these medication and continue to able to get stabilized.
Great. And we have 2 medication-assisted treatment programs here at Zepf Center. You are a medical director for both programs. We have the OTP, or Opiate Treatment Program, and we have our OBOT, which stands for Office-Based Opiate Treatment. How do you help describe the difference between these 2 programs to people?
So we will talk about the OTP first, which is we dispense methadone, we don't prescribe methadone. So the difference between these two is that you come and you have your methadone dose daily, except Sunday when you have a take home that you take it with you and you take it at home. And methadone is a long acting medication used for opiate use disorder, and it works differently than Suboxone. And the way it works, that you have to start on the low dose and then you incrementally increase, looking at the patient response. And there's a lot of other things we have to pay attention to those so we can stabilize those patients safely. And for methadone to work, patient has to take the methadone dose daily. So those receptor gets saturated, and those patients do very well because methadone is indicated for opiate use disorder, and it does help a lot with their reducing their cravings and with no withdrawal symptoms once they are stabilized and they stop using the methadone, stop using the illicit drugs. And the next one is the Suboxone, which is in the OBOT. So Suboxone is also a daily dose, but is prescribed, which means patient gets a prescription. And they can get a prescription starting from 3 days to a week, and then go on from there. It depends on their stability and how it's doing. Suboxone is a partial blocker of the opiate receptor, and it does not give patient the euphoric effect what patient gets when they use illicit opiates, like they use fentanyl. Suboxone does not cause that, same as with methadone. Both these medication will not give you euphoric effect. And with Suboxone, we also have the, I would say, luxury that once the patient is stabilized, not using illicit drugs, and also say, I'm just doing fine, they have an option to switch to once a month injection, which is called Sublocade. Okay. And they get that injection every 4 weeks. They come to the office, they see the provider, and we educate them about the injection. And of course, they get the injection. We keep the follow-up every 4 weeks to make sure there is no infection of the injection site. So far, I have not seen any patient have not done well or had any infection, because we make sure at the agency we follow all the precaution of administering the medication accordingly, and make sure the area is cleaned and follow all the policy procedures. And the third one is Vivitrol. So Vivitrol injection is also indicated for alcohol use disorder. It comes in the oral tablet form called Riva. And Riva is usually if the patient have alcohol use disorder and we see them and they have tried everything and nothing works, they're in and out of the hospital with withdrawal symptoms, and they're constantly been prescribed benzodiazepine, but it works temporarily because you need to have a medication to help saturate those receptors so you do not crave. So Vivitrol, we try with the oral medication for 5 to 7 days, which is just one tablet a day. And then we make sure that patient is not having any side effects from it. Then we give them a Vivitrol injection. So Vivitrol injection is also once a month. And we follow the same routine with that they come and they see us every 4 weeks, and the nurses give them injection. And patient do very well with both these treatment program. Patient can continue their education, they can continue their school, their job, all the social responsibilities. There is nothing that they cannot pursue as long as they want to do it. And we will support them. We even give them a letter to give it to their employer if patients state that I need a letter to make sure that I come for appointment or I come for dosing, that it does not get hold against me at work. So at the patient request, we can help them with anything they want to make sure that they continue to have their jobs and their school and college and pursue all their future goals.
Absolutely. I know you do a lot of advocacy to help people build the life they want to live as they're managing their addiction. What would you want viewers to know about some of the stigma or the judgments towards people who seek treatment for addiction issues?
I would, I always say, and I would always say loudly, do not judge those patients. The society is doing their job, and which is unfortunate, sad. And we, as a provider, working in any capacity in the agency or outside the agency, addiction is a chronic disease, just like high blood pressure, just like diabetes. You need medication, so you are physically depending on it. You are not addicted to it. It's a physical dependency, just like if you're diabetic and your doctor prescribed insulin or metformin that you have to take every day. Can you imagine that if you have a sweet tooth and you took a bite of donut and your doctor say, I'm going to take away your insulin just because you had a bite of donut? No, it doesn't work that way. Your insulin is not taken away because you had a bite of donut. The same goes with the blood pressure. You take blood pressure medication so you can control your blood pressure so you don't end up with a stroke. So the same is with addiction. It's a chronic disease. You need medication. Methadone, Suboxone, Vivitrol, these medications are approved to help these patients get over the initial bump, the craving, the withdrawal symptoms. These are not cure for addiction. So these are the medication patients are physically dependent on it to continue to work daily in their life and fulfill their duties.
We've been talking about the opiate epidemic for over a decade now. And though we have made some progress with treatment, we are still seeing a lot of challenges in terms of people becoming addicted to opiate drugs, opiate medications. Tell us a little bit about how fentanyl has changed the landscape.
So fentanyl, since the fentanyl came, there are more than 250 different kind of fentanyl on the street. Unfortunately, the street pharmacist and doctor is more smarter than our pharmacist in the pharmacy and the doctors working, and the scientist, I would say. So they are ahead of us. They will find any substances to add to the fentanyl to make it more stronger, even though fentanyl is way stronger than what when we had heroin. You know, heroin is very weaker as compared to fentanyl. And it has changed the landscape because it works so fast, it's short acting, you take it, it works on the brain, you get that euphoric effect, and then it will go down. And patient wants to use more because the effect is gone in a couple of hours. And that's how they want more and more. And eventually, in the long term, they don't even get the euphoric effect because you get euphoric or you feel high because that dopamine is high in your brain that makes you happy. Dopamine is secreted when we eat food or we are happy, you know. So for example, if we had a good food we liked and we got a 50 milligram level of the dopamine in our brain, and then we have a really good food that we were craving for it, we may get a release of 100. If we have something else that really excites us, the level can go up. But with fentanyl, that same level of the dopamine can go up to 10,000 times. So it increased that level, but when it increased, the brain is constantly making more dopamine, and then those receptors are dying and drying out literally. But patients are having withdrawal symptoms. So in the long term, patients don't even get that euphoric effect. They are using these illicit drugs just so not having those withdrawal symptoms because those withdrawal symptoms are extremely uncomfortable. Patients with fentanyl, if they are having withdrawal symptoms, versus if patient is addicted to alcohol and they're alcoholic patient can die from it because of seizure if they are not treated accordingly. But with fentanyl, of course, it's extremely uncomfortable. Nobody wants to go through that. But if you get them in the right path, at least you can reduce the drug overdose. So the aim is to get those patients in, start them on treatment, and support them all around, not to judge them, support them, and keep that door open. Never
Yes.
close the door. Keep that door open. And when they knock, make sure they are in and without any judgment, without any barrier. That's my other goal. Get rid of any barrier that you ever see in the clinic for this patient to get engaged. Because historically, these patients take almost 5 to 6 times attempt before they actually engage in any treatment. I have a patient that it's always it's fascinating, and multiple time I have asked her, like, what was holding you from not entering into the treatment? And of course, the stigma is the one, and the other thing is like why I'm not strong enough to handle these things. And she stated that she would come to our Zepf agency on Ashland for 3 months, and she would sit in the parking lot, but she never had the courage to get out of her car, go to the intake, and start the process. And she stayed at the mark of the 90-day. Then she would get out of the car, she would walk in the front door, but she would walk right out back. It took her another couple of months just to get into the intake process.
Yeah.
And now she's in treatment. So these are the things, and fentanyl is a deadly drug. It's killing people, and unfortunately, it's a strong one. So our goal is to engage as many as, and whoever wants to engage and can come, the door is open for them.
Absolutely. Thank you for providing such excellent care for the patients here at Zepf Center and being so passionate about this field.
I love it. I love what I do. And one thing I always did, that every night when I go home, I think and I say, did I do everything what I was supposed to do for my patients? And I sleep good.
That's great. Well, thank you for sharing your reflections today.
Oh, you're welcome.
Well, welcome, Brooke Boudian. How are you?
I'm doing well. How are you?
Good, good. I'm glad that you have come back and rejoined us here at Zepf Center, but this time in a new role in addiction medicine. Do you want to tell us a little bit about what appealed to you about doing some new prescribing activities?
Yeah, well, thank you so much for welcoming me back. I'm excited to be back. I'm excited to delve into this new role, helping with addiction treatment, to kind of learn more about, patients, struggling with addiction and how that interplays with their psychiatric conditions as well, and how I can better serve these clients through kind of helping them both ways.
Great. Well, when you were with us previously, you were prescribing in our psychiatric urgent care. And I remember you were able to see some clients who were here in our SUD residential unit, who noticed that they were starting to struggle with some additional symptoms, some mental health symptoms.
Yeah.
Tell us a little bit about how you approach whole person care. And maybe let's talk a little bit, start to get into dually diagnosed clients.
Yeah, so I loved being able to help the clients on residential. It's one of my passions, to be able to help people delve into what are the root causes, of what's going on with you, and how can we better serve you. Not just treating the symptoms, but also finding that root cause. So for me, that was really important. For a lot of clients, the root cause of their addiction, are psychiatric conditions, that they were maybe self-medicating, with substances. So oftentimes they come in, because of the substance use, and we're able to kind of identify why they're here. Maybe there was something underlying it that is causing them, to use or triggering use. So being able to, better serve our clients, by being able to get to that root cause.
Great. Well, in the scenarios that we were discussing, somebody who might have both an addiction diagnosis as well as a mental health diagnosis, what are some of the challenges that those clients might face?
Yeah, so for clients, a lot of things that it can be challenging are that the two conditions can kind of interplay with each other. So the psychiatric condition, sometimes can play into them, becoming addicted to substances. And the same thing, substance use can, sometimes make worse their psychiatric conditions. So being able to fully serve the client is being able to manage both at the same time.
What kinds of education do you help provide when you're in sessions with clients?
Yeah, so I try to provide to them support. That's a big thing is to be able to be a good support for them. A lot of our clients don't have, good sober supports. So being able to kind of be their cheerleader and, help them understand as well, how addiction is a disease process. And help kind of, normalize that and take away that stigma for them. So that's something that I'm able to kind of help provide to clients when I'm helping them.
Was there anything new that may have surprised you or something you didn't anticipate when you started this role with our OBOT program or Suboxone Clinic?
Yeah, I am surprised, just how many people we see from all walks of life. That is something that's been so eye-opening, to me. I see clients, all the time, just come from different socioeconomic backgrounds, different professions, things like that, just showing that, addiction affects all. So that to me has been really interesting and eye-opening in this new role.
Yes. Is there anything, have you noticed any patterns, the certain questions that people have or needs that they have that they look to you for guidance with?
I would say a lot of people don't understand like the root cause of addiction. That's something that I really, really have been trying to kind of delve into, with the clients, and be able to help them identify what is that root cause. So that's something I'm able to help provide. And then just education on resources. That's a big one. A lot of clients don't know all the resources that are out there for them, and all those, supports that are, in our community, that are able to help support them in their recovery. So I'm able to kind of provide that information and education to clients to help better serve them.
I've heard great feedback about that there's a lot of clients that leave appointments with you and they feel a lot more knowledgeable about what's
Yeah.
going on with them because you've taken the time to talk with them about their diagnosis or about identifying symptoms. For a lot of people, they don't understand the connection between things that are correlated with their diagnosis and then the challenges that they experience. So helping empower them so that they understand more about what they're experiencing, but also what they can do about it.
Yeah, absolutely. Thank you so much. I appreciate that feedback. But it's super empowering to be able to help others. And that's truly something I'm able to do in this role and something that I missed, when I was off work. So I truly have been loving that and, being able to provide that education and just that support, to people so that they're better able to understand, why things are happening the way that they are and what they can do about it.
Great. So you've had that opportunity to see several patients here at Zepf Center. Is there any one particular success story that you'd like to share?
Yeah. So I recently saw a client, and actually, when we're talking about that term, like duly diagnosed, they came in for a self-identified, problem with opiates. But we were kind of delving into some of the past history, and we're able to identify, a history of trauma. So I was able to provide kind of that trauma-informed care, and be able to educate, that that's something we figured out, that this gentleman in particular was potentially self-medicating for so we're able to kind of identify that, and he was really thankful to be able to kind of understand maybe why he started using in the first place. So that was one that really touched me, and I really enjoyed working with this gentleman.
Oh, great. Thank you for sharing that. And it
Yeah.
is true. It's our tagline that hope begins here. But we
Yep.
do create quite a bit of hope for people that there are next steps in their recovery journey and that there are things that they can do to live their best, fullest lives.
Yeah, absolutely. And I've been able to see a lot of clients who, with our services are able to return to work, are able to, more fully enjoy their families, are able to be, just really productive, and great citizens. So that's been really rewarding too, to watch people, fully rebuild their lives. They don't really understand sometimes in addiction, everything that, is kind of taken from them.
Absolutely. Well, Brooke, thank you for your time and your reflections today.
Thank you so much for talking with me.
Welcome, Dr. Snyder. I'm excited that you're here to talk with us for Recovery Month. Can you tell us a little bit about your training and background here at Zepf Center?
Yes, thank you for having me. My name is Dr. Tyler Snyder. I went to medical school here at the University of Toledo. Once I finished that, I went to residency in psychiatry at the University of Toledo. And during those times, I moonlighted at the Zepf Center for a few years and then ended up coming on full time as the medical director of the crisis unit and the detox unit here at Zepf Center.
Great. And as a psychiatrist, you had multiple options of where you could work. You could do outpatient services, which I know you also do some of. Then there's the inpatient service in a hospital setting or like our crisis stabilization unit. But you chose to specialize in crisis services. Tell us a little bit about why that interested you.
Yeah, like you said, I do some outpatient, which I do enjoy, but I kind of like the fast-paced, more acute severity of inpatient in the crisis unit. The crisis unit's kind of that in-between area of inpatient, outpatient, but I do see very acute illnesses, people going through very difficult times. And so the challenge of that is rewarding to me to see people get better. So I kind of like that more exhilarating aspect of mental health.
Tell us a little bit about your role as medical director and how you provide services to clients who are in crisis to help them recover.
Yes. So, as I said, over crisis and the detox unit, but they're kind of we have made them one, where we target both mental health and addiction on both sides because they often occur together. So, as the psychiatrist, I often do the evaluations, figure out why people are here, what's going on, and with that information, we try to one address with medications, being what medications can help the symptoms that they're having, and two, do they need therapy? Do they need groups? Do they need housing, which is another big aspect that we have? So often we'll start medications, watch people try to get better over time, and then refer them to residential treatment for a continued journey of their sobriety or housing, shelters, things that can give them more success.
That's great. Sounds really like whole person care and that you're involved with all the aspects, not just the medication management part.
Absolutely.
Tell us a little bit about, you mentioned dually diagnosed clients, someone that might have a mental health condition as well as an addiction. Tell us a little bit about what you are seeing these days and how you approach that care.
Yeah, absolutely. So often people with mental health don't always want to be on psychiatric medications. And sometimes it leads them down the road of using substances to cope with their illness, whether that's opiates, alcohol, cocaine, methamphetamines. And so often these people, begin to withdraw from those and their mental health significantly worsens, which is often when we see them. So when they come in on that, we want to target both of those and treat both the withdrawal symptoms that they're feeling as well as their mental health symptoms. And by doing so, we hope to, give them success in maybe going to residential treatment or reuniting with family members or something that can allow them to stay sober and on medications if they would like.
Okay. And I know that we have some clients that utilize both our crisis stabilization unit as well as our withdrawal management unit. And sometimes we see these clients come multiple times to Zepf Center. Tell me a little bit about readmission and how you and the team manage that.
Yeah, readmission is a big thing in mental health. People, you see them, they get better and you think you'll never see them again. But substance use and mental health are very relapsing. Even if people are doing very well, the temptation and the issues can cause them to relapse on their substance, or they feel better, so they stop taking their psychiatric medication. And when they do that, symptoms often come back, leading to readmission. Sometimes there's some stigma associated with that, and people get upset when they see the same person over and over again. But I think it's important that we treat these people with compassion and understand that they've maybe burnt bridges with family members, friends, and we're their kind of last line of support. And so we went in this to help people. So let's treat them well, help them. And who knows, maybe this is the time that they don't relapse. So that's what I
Absolutely.
think.
Yes, and I appreciate you always treat our patients with respect as well as the staff. That's important, right? To have that team support. And we need to remember that these are chronic conditions and that doesn't mean that there's a one-time cure. I also think that there's a component about readmission where we're maybe learning a little bit more about clients each time they come to stay with us. Can you talk a little bit about how you've gotten to know some of our clients at a deeper level when they readmit?
Absolutely. That first time they come in, this is a new place for them as well. So although, we're being friendly and open, they're often not going to share all the deepest, darkest secrets of their life. So by treating them with respect, and we see them over and over again, they start to understand that you do care and you're trying to help them. So with every readmission, I feel like I learn new things about them and find out new concerns that we can address via meds, therapy, or social work, case management services. So yeah, I think while we would like them not to be readmitted because that means we're successful, readmission gives us this unique ability to understand the person more.
Great. Well, I know you've worked with a lot of clients here at Zepf Center so far. Do you have any success stories you'd like to share?
I feel like there are quite a few that I've had. When I'm walking down the hallway going to the unit, I see some of them on residential. I saw them at their deepest low and not being able to function, and now they're in residential going to groups saying hi to me in the hall. So
That's
those are a
great.
few non-specific, but we also have one that we saw previously. He struggled with psychosis very much, had a difficult time interacting with individuals, and was very mistrusting. um, had been inpatient multiple times, never could get on medications. Like we were just talking about, he had readmitted so many times that he became comfortable with the staff and with me. And finally, after, I don't know, 5, 6, 7 times, we were able to convince this person to get on a long-acting injectable, which is a type of medication that allows people who don't take medications consistently to have it. And so we got him on that, and he still struggles and has readmissions and relapses. But I found out recently during one of his admissions that he actually signed up for online courses and has been doing
That's great.
discussion points, and told me he has an A and B in 2 of the classes. So that's probably the biggest one that sticks out in my mind.
That's great. I really do think that with the interventions we provide here at Zepf Center, we are helping people live fuller lives. They are having a better balance, whether it's work, school, family, friends. Absolutely.
I
Well,
agree.
thank you for your time today, Dr. Snyder, and thank you so much for the work that you're doing here at Zepf Center.
Thank you again for having me. It was a pleasure.
Welcome, Dominic Cancilla. Tell us a little bit about your role here at Zepf Center.
Hi, thank you, thank you. Well, my name is Dominic, and I am a psychiatric mental health nurse practitioner. Um, I have been working in mental health my entire career as an undergrad in nursing as well. I started off working in the state psychiatric hospital, so great experience with mental health there. I transitioned back and I got my master's degree and working as a nurse practitioner now with Zepf Center.
Great. Well, you are here with us as part of our crisis services in the psychiatric urgent care. Tell us a little bit about what psychiatric urgent care is and how you help support people in their recovery.
Absolutely. So the psychiatric urgent care is a bridge between mental health clients, meeting them where they're at here and now, and setting them up with ongoing care. And there's 2 ways that clients are able to reach me for services. For one, just like an urgent care for physical health, if headache, cold, you need antibiotics, etc., you're able to walk in off the street and get help here and now. We have opportunities for clients walking in off the street Monday through Friday. We are open 9 a.m. till 5 p.m. Clients can walk in and be seen, and we could start a treatment plan. We can, if medication's appropriate, we can start a medication treatment plan. Also, we provide a bridge between inpatient psychiatric hospitalization and follow-up care in the community. A lot of times, inpatient care can be a lot for clients. And when that care is ending, some of the time it could feel like a rug being ripped out from under you. And okay, here's discharge, follow up in the community. I'm able to meet with these clients and provide support, help understanding. Some of the times it's a stressful situation, memory even of your medication regimen, just reinforcing what's going on with their treatment plan and setting them up with ongoing care. Another really cool thing that psychiatric urgent care allows for is I can screen and kind of see where people's different needs are. For example, if someone needs case management, if they have a whole bunch of things going on that could benefit from counseling. We even have a crisis stabilization unit that I can transfer clients to be assessed if it's appropriate for admission for things like step down from inpatient care and things like that.
Great. Well, I know there's a lot of unique opportunities with the psychiatric urgent care. Can you touch on one or two of those for us?
Absolutely. A very unique thing that we allow is meeting clients where they're at, helping to encourage them in their care, even if right here and now they don't have anything or they have little to no financial means for support. And some of the time that could be a barrier. And we provide an opportunity. It's called central pharmacy reimbursement. So essentially, we provide temporary support for things like medication, even if clients can't afford it, while they work with us to establish Medicaid, Medicare. Our financial team is amazing. All of our teams really work together to see how we could best benefit these clients. And some of the times people come in and they don't have these means. They don't have any way of getting medication for themselves. And Zepf Center, it's really an incredible thing that they're able to provide that temporary relief.
Yes, I think the access is incredible too. So somebody who maybe would have waited 2, 3, 4 weeks, 5, 6 weeks to get in with a psychiatrist can actually come see you today if they choose, correct?
Absolutely, absolutely. And that is one of my favorite parts of working with these clients is there doesn't have to be that waiting period. Some of the time there's a huge barrier of even fear, anticipation, getting this type of help. And these clients right here and right now, they make the decision to come in and get help. And I'm able to, essentially celebrate time and time again with these clients. You made it in. I'm meeting you where you're at. Awesome. We can do this now. You don't have to wait 2, 3 weeks. And this is kind of a transition now. Now we can direct you where you need to go.
Dominic, thank you for being the first face for many of our clients and helping them start those first few steps to their recovery journey.
Absolutely. It is my honor. Thank you.
Welcome, Laura Anglum.
Thank you. Happy to be here.
Would you like to tell us a little bit about what brought you to working here at Zepf Center?
Absolutely. I would say that my journey to interest in addiction medicine actually started quite a long time ago, about 2 decades back in a college classroom, learning about the drug war and some of the maybe failed policies regarding that and how much attention was not put into treatment. And just kind of sparked some initial interest. And later in nursing school, had the opportunity to learn about Vivitrol as something that was being offered through FQHC in Ohio. Thinking, hey, that would be great. I'm so glad to see something is optional, is out there for patients to access. And had the opportunity then when I worked in primary care to actually do that treatment. So it kind of came full circle a little bit for me. As I, got into that work, I really enjoyed working with the patients through that Vivitrol program and decided to just kind of pursue some more knowledge, continuing education in regards to that. Along the way, I also was doing some personal and professional research looking at learning about trauma and how trauma can affect the brain, particularly from early childhood. And how much impact that has on somebody's development, and then unfortunately increasing their risk for having issues with addiction later in life, as well as mental health challenges. And through that experience, I learned that the Zepf Center had actually pursued certification for trauma-informed care. And serendipity had it that there was a job opportunity around that same time of learning about that, to work specifically in addiction medicine, which I had been very interested to try to find an opportunity. So all those little links along the way kind of led me to here.
Well, we're thankful for that, for sure. And now you're here as one of our prescribers in our OTP or our methadone program. Can you tell us a little bit about how your background in primary care has informed your role now prescribing methadone and working with our
Sure.
clients?
Absolutely. I think having that solid background in primary care has been very helpful just to be able to look at our clients as like their holistic health or their full health picture. And, knowing so much about chronic illness and how that might show up and affect their addiction treatment, and vice versa, how that, years of addiction can then affect somebody's health and the different ways that that can come about. Also, just kind of having perspective for what other healthcare someone should be accessing in addition to their addiction treatment, and being able to kind of advocate for that with them and hopefully provide some comfortability of how they might access that and what that might look like if they haven't really participated in medicine or in the medical system. I think that just kind of that ease of knowing the overall picture of what might be going on in their life, physical and mental health, also, what kind of treatments they might be on or could access if they were able to engage in that other care.
Right. Well, since our focus really is on Recovery Month, let's talk a little bit about stigma, because stigma is one of the things that can be a barrier in people's recovery. What kinds of things have you seen in your work in our OTP as it relates to stigma?
Yeah, stigma, unfortunately, still does play a huge role, both for the clients themselves and then in the wider, community culture and in the medical system. I honestly see clients kind of having internalized that stigma sometimes, and even from the first days of their approach to treatment. There's certain levels or expressions of guilt or shame. And I think it affects how they even approach the treatment, thinking that they should be able to get in, get help, get out, and kind of thinking that process shouldn't be that involved, or that it's potentially a chronic illness and that there's chronic treatments available for that. I unfortunately also definitely hear about clients having a lot of family members that don't support treatment, don't understand treatment, think that it's just another form of addiction, and that can lead to just a cycle of, as somebody's pursuing treatment, unfortunately having to kind of continue some behaviors that may have gone along with their addiction, like hiding, lying, not being able to be fully transparent with some of those closest people in their life because they're afraid they could lose them. And that is something that definitely continues to come up. And then certainly in the medical system, other healthcare providers, even though, this is the best evidence-based treatment for addiction, they still, there's just a lot of people that aren't aware of that. Or again, they may look at it as another form of addiction, and can, use very stigmatizing language to patients when they interact with them, maybe in the ER, hospital setting, other specialists, and unfortunately, even people in behavioral health, that happens. So it's definitely prevalent, although I think certainly there's some progress that's been made in recent years. So
Yeah. As we're talking about evidence-based practices and MAT or medication-assisted treatment, what would you really want our viewers to know about these evidence-based practices?
That medication treatment for addiction is the evidence-based practice for treating it. There's just really no question left when you know the research that's out there that treating opioid addiction, particularly with medication, is the number one recommended treatment. Of course, ideally, that's happening alongside of behavioral health treatment, behavior modification strategies, engagement with other social support services. However, first and foremost, somebody can stabilize with the use of medication alone if that's all they're willing to engage in initially. And a lot of times that leads stabilizing some of those physical symptoms, particularly, I think can help people have the space and time then to engage in more care, in more services, start to even see some of those mental health things that they maybe had been masking or suppressing through the use of substances.
Or even to work on trauma, to come full circle with
Absolutely
the topics we're discussing. I know you collaborate a lot with our counseling team and as well as with the other prescribers to really encourage a full menu of services here in addition to the medication assisted treatment.
Absolutely. Ideally, and the clients that have this most success do engage and use all of those services. So
well, you've seen a lot of clients here. Is there any particular client success story that you'd like to share?
Yes, and I've been here almost a year now, and in that time seen, just dozens and dozens of success stories. So many of them well before I even came here, and I've had the privilege to kind of see and understand how they got to where they are. I would say there's one client in particular that it comes to mind of somebody who started since I've been here. And he had been someone who kind of came in and out of care for some time, had been with us previously, re-engaged. There were some legal aspects to what was going on at the time of engagement again that I think helped also provide a little bit of motivation at that point. He definitely had some setbacks along the way, but kept staying engaged in care. Even despite that, really engaged with the counseling services and started to kind of get some success over a few 3 to 4 months or so, earning take-home doses, which is kind of a privilege here when you start, being able to do better or achieve some sobriety with care. He started at some point also similar to what we're just talking about, starting to really see some of those mental health struggles that he had and hadn't been fully dealing with, and then started to have a willingness to actually, work on that or go talk with somebody else. And has described a few things he's been able to do in his life, over the course of the 6 to 7 months now, or maybe a little longer even, that, he just had never done before. So, and success more with family, his employment and other things. So, yeah.
That's really exciting. That's great.
It is. And there's so many success stories. I think that can sometimes get lost when there's lots of hardship and difficult things going on, but there truly are so many success stories.
Indeed.
So,
indeed.
yes.
Well, Laura, thank you for your reflections today, and thank you for all the work that you do here at Zepf Center.
Happy to be here. Thanks for taking the time with me.
Hello, Usman Chima, and thank you for joining us today for our conversation on recovery. We've just celebrated your 1-year anniversary, which is really exciting for being here with us at Zepf Center. Do you want to tell our viewers a little bit about what work you did previously, as well as all the opportunities you've had at Zepf Center as a prescriber in the last year?
Thank you so much. Hello. And yes, I'm excited that it's been already 1 year. Seems like a couple months ago. And looking forward to many, many more years. So before starting here in September of 2024, so I worked in a FQHC, which is fairly qualified health center in Fremont for about 7 years. And there was a primary care outpatient. And that was all inclusive of chronic acute illness, anywhere from infants till geriatrics. So all the chronic conditions, including diabetes, cholesterol, hypertension, abdominal pain, and the vaccinations for kiddos, and the annual physical and health measures, and really enjoyed it. And the one of the biggest thing over there, which I learned and did, was the education, because the role of primary care is that we should all the time we should educate and treat or screen patients so that they don't go to the ER urgent care. That's the primary role. And so I definitely enjoyed it. And having that in mind, also did the Vivitrol treatment for alcohol abuse. And so some of they had different locations, and one of the location was in particular was in Fostoria. That was one of the underserved. And some of the clients were just like in Zepf Center. They may walk in for refill for hypertension or diabetes, and then they will ask for opioid or pain medications. And then you had to learn and talk with them and explain them. Sometimes they will get upset or so. But that coming here, that also, I was not in a mindset of like having typical stigma in mind for our clients, the population. So that really helped me. So one of the things which I want to discuss actually in particular is how to connect with our clients, because when they and also when I joined in as just for OBOT or methadone treatment, and going forward. So I was asked if I can help out in our primary care in Nebraska, which I did a couple of times. Enjoyed that also. Actually, happened to see two of my old patients from over there also.
Wow.
Yeah, and and then also I was asked if I can help out with the OBOT with Suboxone. So I've been doing that since June. Suboxone, Sublocade, Subutex, and Vivitrol also. I really enjoy it talking with these clients, because the reason is that they already have lost everything in their life. And they are always thinking that, okay, everybody who sees them, talk with them, stigma. Just today, I spoke with a client that client has some college degree, SDNA degree, dental radiology, but job isn't an issue just because of the history, unfortunately. But the client is working, and we talked, okay, well, just keep your chin up, keep working, you'll get through it. So, so getting connected with clients. So when they come in, they always think, okay, well, here's another warm body. So we have to narrate the whole story again, explain what happened, how it started, and all that. So in a way, they are right. But I think what my perspective is, sometimes we just have to sit back and listen. Sometimes they don't want it to be disturbed or abruptly stopped and ask another medical question, because they just want to be heard, listen, and sometimes again the empathy, and just talk with them that, okay, well, yeah, it happens, okay, do this counseling, education on my whiteboard back there. So I have all the education material also, which is the side effects of all the opioids, stimulants, and sedatives, and also the primary care thing, which is the DASH diet, which is dietary approaches to stop hypertension, what to take, what not to take, how many calories, salt intake, and all that also. And I have noticed that when in the beginning I was just talking to them, I was explaining, educating, they were not really paying attention. But when I wrote down, and when I was talking to them or typing, and they were constantly reading and asking me questions, what is it? Okay, I didn't know that. It has that side effect or so. So that actually really helped, and I'm glad that I did. So back to listening to them. So it's listening also, and then not just the negative reinforcement, it's the positive reinforcement also, that you tell them, okay, well, that is behind you. That was yesterday. Go to church, go to meetings, come just talk if you don't think that okay you're not moving forward or you're relapsing. Before that happens, and also we talk about the barriers and the boundaries also, what you need to do. So it's education, just talk in a polite manner. Sometimes they get irritative also, and so that is very important.
It must be working. You get a lot of positive feedback from our clients, and this isn't the easiest service to provide. There are a lot of boundaries that you have to set in terms of your medication that you're prescribing, and being able to kind of walk that balance between keeping somebody safe and also providing them treatment. What are
That is
some of
true.
the other strategies that you use as you're developing rapport with your clients?
So I always tell them, let's say if somebody has the 2 weeks of take home, so I keep reinforcing that, okay, you have it, way to go, awesome, but keep in mind that don't get shocked if you're missing the doses or if you are not showing up for your bottle checks, counselor meetings or so. So then it may be taken away. So same way, if they are not showing up for their daily dosing, counselor meetings, and they are still using the illicit, keep informing them that hey, your dose may go down. Because I have noticed that if I have taken the dose away from them, they get really irritated that they think that okay, I cheated or I didn't explain them. But if I reinforce and tell them, they don't, then they understand. And then I always explain why. Because yesterday actually there was our dosing nurse. She actually called. There was one client who was dozing off, nodding, and was on significantly high dose. Brought back, checked, and was positive for benzo, slurring and all that. So again, sat down, explained why we want it, because you can have a respiratory failure. So, and also going forward with what medications, like even over the counter, what you should take, what you should not take. They have already been provided the paperwork, but sometimes they forget.
Yeah.
Same way with the take homes, that okay, when you're called, just respond. We understand that you can get busy, but just call and reschedule it. So things like that. So yeah,
So very
the
important to
client,
have that open communication. I can see how that helps with the rapport you have with clients.
absolutely, yes.
Are there any success stories that you'd like to share with us?
There is one in particular. I mean, there are many, but one in particular that one of our female client about 4 months ago came in, and during our first initial induction meeting, she could not just sit down. She was just walking. She was crying. She was screaming. And when I asked what's going on, is it nausea? Is it abdominal pain? And she said, no, my body's on fire. I cannot sit. I just want to doze and go home. We had discussion. I said, okay, I will call you back in a couple of days. Let's get through this. So started it in a week. When she came back, there was a huge difference. So now about 6 months down, so she's already 4 months plus, she's already on 1 week of take home. She is doing much better. She could not even believe, looking at her chart picture, that it was her. And we talked, and she said she's going to actually change it, and she's going to have a fresh photograph with smiling face.
That is wonderful. Thank you so much for sharing that. And thank you again for the work you're doing here at Zepf Center and being part of our patients' recovery journey.
Thank you very much. I appreciate that. And I love what I do.